Hello, my name is Connie Hess. I'm an interventional cardiologist at the University of Colorado. And today we'll be discussing quick tips for the detection of PAD and disparities in care with a focus on intervention. Shown here are my relevant disclosures. So I'd like to start by just walking through a clinical scenario that I encounter not infrequently and that you may also see in your clinic. But this is a 72-year-old man who was referred for non-healing wounds on his toes. He has a past medical history of coronary artery disease, diabetes, and hypertension, and he is currently on aspirin, metoprolol, lisinopril, and insulin. He does have a history of former smoking. And so right off the bat here, obviously I'm an interventional cardiologist, I see this a lot, but I'm worried about peripheral artery disease or PAD, right? Because he has non-healing wounds on the toes. And so my first thought is, does he have risk factors for PAD? And it turns out he has almost all of them and many of them. If you look at this chart here, the data show that existing coronary or cerebrovascular disease is one of the strongest risk factors for PAD. Former or current smoking, diabetes, hypertension, age, these are all things that should trigger you to think about potential risk for PAD in patients when you're seeing them in clinic. Now, the other thing to note is that the clinical presentation of PAD is variable. So this patient, I'm worried about, critical limb ischemia, which is defined as rest pain or tissue loss in the presence of severe PAD. But you'll see on this pie chart that that really represents the minority of patients. Many patients with PAD actually are termed asymptomatic because they don't have the typical limb symptoms, that they may have changes in gait or balance. And only 15% of patients have that typical claudication that we learn about, where you have exertional-like symptoms that resolve with rest. So the diagnosis of PAD is important and really begins with suspecting the disease. History is very important. So exertional leg symptoms or leg fatigue, wounds, rest pain, just as this patient had. These are important things that might trigger suspicion. Physical exam is extremely important. So does the patient have hair loss on the legs, lack of palpable pulses, bruits when you listen? Do they have pallor when you elevate the foot or resting kind of dependent rubor? In terms of diagnosing PAD, the test of choice is the ankle brachial index, and that's shown here on the right in the graphic. Take the higher of the posterior tibialis or dorsalis pedis on the right and left, and then make a ratio with the higher of the right or left brachial arm pressures. And you can see that below 0.9 is a diagnosis of PAD. Now, imaging, of course, is also important once you've diagnosed PAD, and that can include ultrasound, CT, MR, angiography, or conventional contrast angiography. And this is important not only for understanding level of disease, but also planning treatment. Now, let's just pause and think, why do we want to diagnose PAD? Why is this important? Well, patients with PAD are at very high risk for cardiovascular and limb events, and that includes things like myocardial infarction or stroke, peripheral revascularization, acute limb ischemia, and amputation. And in particular for this patient, I'm very worried because he has critical limb ischemia. And so the 6-month outcomes shown on the right here for patients after critical limb ischemia are not good. You can see that 45% are alive without an amputation, 35% are alive but have undergone some sort of amputation, and 20% are dead. Now, unfortunately, we have also noticed that there are significant disparities in amputation. And if you look in the US, there are disparities according to geography. So you can see in the darker color-coded states that there is greater use of amputation in the South, for example, relative to the North and the West. There are racial disparities. So this is an overlay of use of amputation, and you can see that it actually correlates with majority Black areas in Detroit and Atlanta, for example. There are socioeconomic disparities as well. Shown here is a map of Los Angeles, and you can see that there was greater use of amputation in poorer areas. And finally, there are also disparities noted in the use of pre-amputation vascular testing. So in this graph, you can see that patients undergoing foot above the knee or below the knee amputations, these graphical lines show the percentage of patients who have pre-amputation vascular testing. And the first observation is that there are many patients who undergo amputation without any testing, and that's alarming. Beyond that, this study showed that the testing is ordered less frequently for women younger patients, and patients living in rural areas. So again, a lot of disparities to understand here. And what I'd also like to point out is that the rates of peripheral revascularization are inversely proportional to rates of amputation. So all these places where we've shown that there are greater rates of amputation also correspond to lower use of peripheral revascularization. So disparities in that treatment modality as well. So if we return to sort of thinking about treatment for PAD, of course, the goals are to prevent progression of disease in patients that are asymptomatic. And in those who are symptomatic, we want to reduce the risk of cardiovascular and limb events, including amputation. And of course, we want to improve function and quality of life. Now, lifestyle modification is important, as listed: diet, exercise, smoking cessation, control of hypertension. Medical therapies, including lipid-lowering therapies, antithrombotic therapies, and diabetes medications are important. And revascularization, as I mentioned, is an important modality. Now, in patients with claudication, this is mainly aimed at symptom relief and improvement in quality of life. But in patients with critical limb ischemia, this is important for limb salvage. As I've just shown you, there are a lot of disparities in use of revasc and amputation. And so this is important to keep in mind. So if we return to the patient that came into clinic to see me, this patient was diagnosed with PAD and critical limb ischemia. He underwent peripheral revascularization and had subsequent healing of his wounds. So we were able to salvage his limb. And so in addition, of course, to the revascularization, we did treat him aggressively with medical therapies for secondary prevention. So in summary, I'd just like to leave you with a few facts. So PAD is associated with high risk of cardiovascular and limb events. Diagnosis of PAD begins with suspicion. There are significant disparities in use of revascularization and amputation in PAD. And so therefore, better education for patients and providers about PAD and better understanding of these disparities and barriers to care are needed. Thank you very much for your attention.